Right. Yes, because
And 17th being the World Patient Safety Day, we plan to do something big around that. So this is sort of building to that big event in September.
Right. So it will culminate on that day.
That's
wonderful. Yeah.
So we hope to make patient safety a household sort of word in every house. So people know that there is something called patient safety, and they need to be aware of what their roles and responsibilities are, and what they should be doing if they see an adverse event, or if they see somebody else having a problem, or what questions they should be asking. Hopefully this will lead to that. I know this is a very small effort, but like they say, each drop in the ocean, makes up an ocean. Yeah.
And somebody has to make a beginning.
I agree.
No, these movements take time, to build traction, but once they do, then they spread. So I think it's the inertial energy that we need to put in. And I'm so glad and compliment you on starting that, all of you at PAIR.
Thank you. Also, WHO last month had a high-level policy forum for national action plans on patient safety. And there is some guideline that's now coming out because though many countries had a national action plans, they didn't have the money to roll them out. So that commitment is being sought now. And the document that will come out from this high-level policy forum will allow governments to invest into patient safety in a real way.
Okay, they'll build around it.
Yeah, so the investment is happening in bits and pieces, not across the spectrum of patient safety. So hopefully these guidelines now and the directions from WHO will generate more interest in funding for patient safety from governments.
Yeah.
Okay, we have just 4 more minutes.
Will you be introducing? You had a dry run where you asked us to introduce. Is that part of our?
I will introduce you. So
okay.
yes, so this is much easier. So it's.
Just to lend credence to whatever we say or speak or think, only from that angle.
So is Avinash, will you be giving us a hint on when this is going live?
I think it's already live.
If it's live, then audience can hear us. I don't think it's live.
No, it's live right now.
Okay.
Hello, Avadip sir. I have shared the virtual background. I hope you have received it.
Yes, I did. Thank you.
Wanted. This is not without. I'm India.
Hi, Mr. Kavaldeep. So, shall we start?
Yes, so is it 30? Yeah, thank you.
Yeah.
So I will share my screen now. Thank you very much, everybody, for joining us today on this first patient safety webinar 2022. As you know, this webinar is forming part of a much longer commitment of all the organizations engaged in this project. And we are all working towards the WHO's World Patient Safety Day, which has been themed as medication safety without harm. And it's very important for us to, post-pandemic especially, to come to this consensus and agreement globally and see how we can all contribute towards medication safety and make sure that our patients, our families, and most importantly ourselves are safe when we take medication and help others take medication. I have with me an illustrated, quite an illustrative panel today, and I would say they represent different angles of the same elephant, which is that patient harm from medication. And each learned giant, I would say, knows a specific aspect of this very thoroughly. And therefore, when you put all of them together, when you go around the issue, you will have a very good understanding at the end of this. And you will understand that giving your valuable time on Saturday was profitable. So without much ado, I will introduce the panelists, and then we can start off in that. So I'll share my screen now. Okay, thank you very much, everybody. So our first speaker on this is Professor Sangita Shema. Many of you have read her papers, and she's really well published. And if you go on to Google Scholar and Google her names, she's been at the forefront of thinking on this. And it's from some very intense work on medication safety. She has come from, as a president of Delhi Society for Rational Use of Drugs. And she's got some string of high quality policy advice and policy work she's been undertaking across the globe. She's also serving on the ethics committee of several national and academic institutions. And on that, we must commend. I think we must make everything we do ethical. I think that's something that and clearly from the state nodal officer for AMR containment, it really makes important, because AMR and medication safety are going hand in hand. It's like almost tight glove fitting us. My next speaker is Professor Nadria Chaturvedi. Again, Professor Nadria comes from the Institute of Management in Ahmedabad. She brings that high-level insight and the business acumen you need to this patient safety, to know where it needs that entrepreneurial skills, where you need management skills, where you need culture change, where you need support, what they call capacity building, and really a systematic and systemic approach to changing patient safety. I really enjoy this. Is a very, having spoken to her during our previous preparations, I think I really enjoyed her amazing insight into this. Again, Professor Chaturvedi isn't shy of helping out charitable institutions. She has done a lot for the Asim Charitable Education Trust, and always has been in the forefront of taking care. And so this issue is second nature to her, I think. So I'm so glad to welcome Dr. Chaturvedi. And then I've got, from my part of the world here in the UK and European Union, we have got Maria Maveris. She's from the European Medicines Agency. We meet regularly, or we used to meet regularly when the European Medicines Agency was in London. But with Brexit, we do meet up now and then when before this whole pandemic hit. In Amsterdam now, we are planning to do that. And it's very important to bring that oversight she brings from the European Medicines Agency, that here it is 27 countries following the same framework and ensuring that medication safety is observed through the life cycle of the medicine. It's from first stages when the medicine is what in there, how it's packaged, how it's instructed, right down to how it is distributed, sold, etc., and then accessed even with online as well. And then most importantly, they use what is called the patient consumer working party. This is something that I'm encouraging those who are from regulators who are joining us today. Please take particular attention to this. Please do include the end users in this. There is no other world where this doesn't happen. Apple company wouldn't be where it is unless it had involved Apple users. For some reason, regulators think that not including patients in is a very wise thing. It's not. We are not interfering with your action. Again, Maria has got that insight. She understands that microbiology very intensely. I think for even biosimilars, when you've got products that are coming in and during vaccines as well, it was very important to have this kind of insight into them. Lastly, but not least, our good friend Alice Lajani from Malawi. Alice is a board member of IAPO. He's a patient for patient safety champion, has really advanced at WHO. He has pushed patient safety in low-income countries. And more importantly, as an ombudsman, sits on that judiciary, quasi-judiciary kind of judicial position to know what needs good regulation, good approach, and good science. I will then now ask Professor Sangita to start off the ball rolling. So if Professor Sangita can present, it will be great. Thank you.
Thank you, Dr. Kavaldeep, PAIR and IAP to invite me to this very important webinar series, Patients for Patient Safety. Good afternoon, good evening to all of you. Can I have the screen share? Can you see my slides?
Yes.
Okay. Okay. Today I'll be sharing, talking about public awareness and medication literacy, how it can help in improving the patient safety here, and I'll share some of my experiences of working in this area for patient awareness. We need to worry about medicines. One reason is that we have too many different drugs formulations which are available, which is so confusing to doctors as well, you know. And on the other hand, we know, you know, they save life, improve quality of life, but at the same time can be dangerous because if not taken properly can lead to medication errors, adverse drug reactions. They are of course expensive and have the misuse potential, abuse potential with them. And lack of medication literacy is a barrier to patient safety. One particular, you know, it is growing as a barrier much and much more because of the rising rates of per capita prescription drug use by the patients, you know. And we know that the public knowledge about medicines, their personal health is limited. So therefore, public engagement is pivotal to any informed or health literature population. And there are several gaps when we want to engage the public in this. They do not know about the basics of safe use of medications, such as storage, where to store at home, how to use them, how to dispose of expired medicines, leftover medicines. And of course, we know that many of them engage in self-medication, sharing medication with others. So all this is happening because of the lack of access to information about medicines. And of course, adverse effects are, they are also contributing to the harm to the patient. And this is a matter to us because low literacy is associated with poor health outcomes and higher rate of chronic illness, hospitalization, mortality, and use of emergency services. A lot of it can be avoided if people have good knowledge about how to use medications safely. And this is because of poor self-management skills due to lower level of knowledge about the disease, about the medications. And also, generally, since patients are the utmost consumer of healthcare, and all the efforts going into the diagnosis, treatment, providing healthcare will go waste, if we are not able to provide satisfaction. And this is largely responsible for lower satisfaction with doctor poor communication. And of course, greater medication harm results because many patients have they are on multiple medications, they are having multiple comorbid illnesses, patients who cannot communicate well, or when they are seeing more than one doctor, so they may be having several prescriptions with them. And at the end of the day, they may be confused which one to take, which one not to take. There may be some duplication or omission when they see more than one doctor. And also, they are not able to take active role in their own medication use, and therefore they may not come for the follow-up. There is lack of monitoring, and especially those elderly, extremes of age, elderly and low, children and babies who require dose calculations. So these group of patients need special attention. And of course, everyone has a role in addressing medication literacy. Particularly, it is best to provide information about the medicine when the service is being delivered, and an opportunity should be given to the patient to ask questions, resolve any queries, their own queries or their family's concern prior to prescribing, dispensing, or administering medicines, so that they can make decisions about treatment choices and safely use these medicines. But at the same time, we realize that they are the important stakeholders and the end but there are challenges, particularly because of the diverse population needs and their expectations, variation in health literacy level, and lack of awareness about safe use of medicines. And sometimes even the notions or the definitions, the words used by them, and for example, they mix up seriousness with severity. Even doctors also do that. Many of times anything which is severe is taken as serious, but which may not be true. So same is, this poses a great challenge when it comes to public education, and particularly elderly people who are having multiple diseases. And in the COVID times, all this, requirements or the need for medication literacy increased ever since, because these patients were quarantine, they were under isolation, there were no one to take care of them. There were issues or concerns, questions about the disease itself, what to expect, what not to expect. and because they were isolated, they were these people, these patients were not being, they could not express their needs, and therefore timely, they could not reach the healthcare system in a timely manner. So these are some of the challenges which were faced, but at the same time, these times, the COVID times particularly, have shown us, how technology could help us, and how technology could bridge the gap, even though we were physically distanced from each other. But technology brought us all together, and today we are here for the webinar, and we could use this very effectively for promoting public education here, so that we can better engage. Before the COVID time, we never realized the potential of the technology in improving the public education, and I think this is COVID is very good example for that. Then better engagement with patients, consumers groups, then collaboration with industry to encourage reporting, patient involvement in pharmacovigilance, and then better engagement with mainstream media to create positive news stories. These are the opportunities, and international collaboration and adoption of successful strategies, that sharing of those experiences can motivate many others to take up this. So there are 5 major strategies which can help us improving medication literacy. First is, of course, the written health information, using plain simple language which they understand. Many a times patients do not understand the language, the signs used by the doctor in the health information. And then prescription drug labels, like storage instructions written on the drug label, they don't understand this, and they end up in saving or storing these medicines or using these medicines in a wrong way. Then verbal communication, certainly use teach back method is one of the very well-known effective strategy to do public education. Then risk communication, using formats which aid understanding. Many times we say this is a very common illness, or this is a rare disease or something like that, which they don't understand. So maybe we use 5 in 100 women will get this or something like that, so that they understand this better. And last is shared decision making. Encourage patients to express their preferences, so that a shared decision making can be made. And medication literacy, we can engage these patients in reporting of adverse effects. Many times doctors underestimate certain side effects, and they may not report it at all, or they may over estimate others, whereas it is the patient who is experiencing these sides. For example, fatigue is one of these, maybe one of the side effects which would be underreported by the doctors, but it is the quality of life being experienced by the patient, which for him, this describes its impact on their life. So that is why it is important that they can be engaged in reporting of adverse effect. Increasingly, awareness wasn't there earlier, but now people are becoming health literate, people are participating, and even the national governments are trying to engage patients in adverse effect reporting. And it will also bring about identification of quality issues and greater engagement of the patient, to create ownership of the patient in their own management. So reporting systems, but many of them do not, one of the barrier is that they don't know when to report, how to report, where to report. So reporting systems need to be set up, and these need to be, they need to be made aware of about the various channels, such as toll-free numbers, emails, websites, web-based platforms where they can share their experiences of adverse effect. So other aids which can help a patient in their education is one very good document is discharge summary, which is usually neglected. This discharge summary can describe about the medicines they need to take, how to take, when to come back, when to report in emergency, where to report, whom to report. All these things should be catered in the discharge summary. Then other aids which can be utilized are medication calendars, schedules, or medication people call it by different name, but the idea is that they adhere to the timing, the way the medicine has to be taken, such as pill boxes may be used by them, or sometimes review of their medication with their own medication, particularly for elderly, because they forget. So, and whenever there is a change in any brand name, they get totally confused, and their adherence is goes haywire. So medication review, and then many times these patients are seeing many doctors. They are taking over the counter medicines, they are taking herbal medicines, Ayush medicine, or they may be taking vitamins, but they may not report this to the doctor, or even if they want to do it, they may not be able to do it because they have no idea which medicine is being prescribed by whom. So a up-to-date list of getting this is very important. People use the word medication passport. This is one place where all the medications being taken by the patient are recorded, and he has to just carry this. And allergy record, this is another area which is can cause harm to the patient, but very rarely this card allergy record or the card is given to the patient. So these can be very helpful. And then of course technology is also helping. Two-way messaging systems on various hospital sites can also help them in aiding this. Then other stimulating awareness is another area. This earlier I was talking about the targeted patient related information, how this can be improved. But if you generally raise the awareness about the medications literacy, and this can help in preventing harm to the patient. One very good example is the crackers drive to reduce pollution. So something can be used here for medication literacy through radio, television, or through pharmacies, camps in community, campaigns in schools. Celebration of awareness week is very one good way of doing, or health talks, newsletters. Some hospitals are organizing morning talks on or optimum medication use, and they're talking about the disease prevention, healthy lifestyles, etc. So we need to develop and display public education materials at prominent sites, especially in the waiting area where the patients are waiting. They can utilize this time, and they can be educated about these medications. General common areas that we use are do's and don'ts, when to take medicine, when not to take, particularly about antibiotics, not to self medications, how to handle leftover, how to store medicines at home. Like this I will show you our work, what we have been doing. Then also you can talk about the red flag signs, when to report early, immediately in emergency department. Many times patients suffer from serious side effects or harm, but they don't know, they don't recognize these red flag signs. So one can use this opportunity and use these as a public education materials. We at DSP RUD had been doing these public education campaigns, and we've been trying to find out innovative ways, how could we engage them. So we organize games, with them, melas with them, wall paintings with them. We made also films on these, to engage more. Then recognizing that the schools are very important, place, where we can reach out to large number of people, and we can, particularly, we chose the topic of antibiotic awareness, and teachers were trained, and then they further held health talks with the students, and as a result, lakhs of students were exposed, using this. So in 2019, we did all this in a physical mode, one-to-one mode, but because of the COVID distancing, but this did not stop us. We went online. All activities of this campaign were done online, and all schools in Delhi were, the program was held, and the students were engaged in that.
Professor Shema, you
Yeah,
have.
I'm just finishing. I'm
last
just
one. Thank you.
finishing. Okay. So like this, we have been doing this, so, insulin, how to use this insulin, how to manage diabetes, how to, because many of them don't know. So how to, when to increase the dose or like that. So we've been doing this, campaigns on social media. So I think social media power, we need to recognize this more and use it more and more, to reach out these messages. Awareness weeks, thematic messages. For example, when we had Karwa Chauth, we talked about diabetes, fasting. When we had Diwali, we talked about inhalers because of the pollution. Then we targeted the young children who are very body fitness freaks, so messages were targeted like that. Then how to prevent accidents at home, public education, so that they are more aware. And I'm very happy about this school campaigns. Day before yesterday only, I saw one of the teacher made on the similar note, she made a YouTube presentation, and she had kept it there. So that shows the acceptance, and that shows the importance. One campaign led to so many motivated teachers coming up and teaching their students on many of these issues. Thank you.
Thank you very much. It was very lovely hearing that. I think it was a very good starting point to see how we can all work on this. Next, I will ask Professor Chaturvedi to fill in that very crucial gap. What is the role of the patient in this? And I know from experience, people joke about, we have got this certain tendencies. There's a case of where a dietitian had prepared a wonderful diet plan for in an individual, and then, gone through hard times, uploaded it onto her iPad and everything. And then she asked the person, any questions? And the woman says, do I have to take this before or after my meals? So yes, the patient has a role to play. It's patient control, patient engagement. Professor Chaturvedi, it's over to you now to share with that insight. Thank you. And you're mute. Yeah.
Thank you, Dr. Kavaldeep. Yes. All right. Thank you for PAIR, and thank you for IPO for doing this very important webinar. And I'm sure Professor Sangita has given us so many insights, so many inputs, and all of them are going to be highly, highly useful. Many of these I myself reverberate, and I would like to add a few other slants to her presentation and take it forward, particularly from the patient's point of view. The very name of the topic is engaging patients in medication safety and medication without harm. So why does it happen? And is it only the doctor? We assume that it's the medicines that is causing harm. But I think taking a step backward would be very useful. Understanding the patient would be even more useful, because whatever we say, think, usually applies to urban populations. literate populations, the better off populations, because that's where more of the medicines are being consumed. But that's not so. Illness doesn't choose, right? It goes to anybody and everybody randomly. So the very role of medicines in life, or the importance, is completely missed out in many populations, particularly in non-urban or semi-rural and tier 2, tier 3 cities. And poverty, yes, one reason. Lack of education, yes, one reason. But that does not give them the handle to seek out help when they need it. They don't even understand that they need help. So it's not just going to the doctor. It's the medication without harm. It can also be harm without medication. So sometimes nobody goes to the doctor, nobody takes the medicine, and that creates even more harm. So particularly where there are diseases or psychosocial issues or social taboos, or even myths surrounding certain diseases. My experience with cancer patients, with drug abuse, substance abuse, youth, children, my experience with even mental health adults shows that people do not want to talk about this particular ailment for fear of loss of a job or social stigma or what will people say. And so the longer the delay, the worse the symptoms get. The disease doesn't wait. And by the time they really need to go to the doctor, it's too late. In fact, we have seen in several cities, they do go, but they get a wrong diagnosis. Yes, Tamanna, you can share it. Tamanna, will you share the screen? Yeah. So yes, the next slide, yes. Next slide, please. The challenges. Thank you. So the myths surrounding it, the beliefs, the cultural beliefs, all these would be we would need to look at it, acknowledge them, and approach them for the public education and public knowledge that Professor Sangita was talking about. Another very important challenge is the pure security. I don't mean safety, I mean security. The access, the availability, the economic problems that medicines, high quality, high expense, high cost medicines. In fact, we saw this very much during the pandemic when people had to go back to their towns. Delhi, incidentally, has very good hospitals, as everybody knows, and a lot of states, northern states, are catered to. The patients come from all over, all these states, whether it's Bihar, whether it's Punjab, whether it's UP, and they get treated in well-known hospitals here like AIIMS or Safdarjung. But they do go back, they cannot stay here forever. And when they go back, they do not have access to the same medicines that were prescribed. So that leads to another challenge. Then, of course, is the basic discipline, which comes from the knowledge. Sangita, next slide, please. So we'll take this in 3 sections. I'll just cut it down into prescription level, patient level, and pharmacy level. So let's look at the 3 angles that we could approach in overcoming the challenges that I just spoke about. Tamanna, can we go to the next slide? Prescription level. So at the prescription level, we assume that the doctor has given all the medicines, and which he does or she does, and maybe there's a lack of understanding or a gap. Now, again, I believe it's a two-way street. Good health is not just the duty of a good doctor or a care service provider. It is equally important that the patient, the family engages in this. And the first stage of engagement is disclosing all your symptoms, whether it's related, whether it's unrelated, whether you think it's unrelated, but the entire history and complete disclosure. Again, we've seen so many incidents that if a girl gets cancer, they never talk about it. If it's anywhere in the gynecological, in the reproductive system, it's never spoken about, because what will people say again? Men do not talk about it because they'll lose their job. So this doesn't help anybody. And as she pointed out earlier, the continuity of medications or the continuity of ailments also form part of the history, which is allergies or incidents that anything occurs. So only when you disclose it fully, and by reverse, the doctor needs to have knowledge and keep a calendar or a continuity of what the patient entirety is about. Maybe there's a history in the family, not just about the person. So the beginning, if you begin at the beginning in the right manner, it would help a lot. A lot of patients also take self-medication. Dr. Google and Dr. Local Chemist comes in handy for small ailments, which then grow to big ailments. So when we say that people do not have knowledge, sometimes they do, this internet works both ways. It gives you knowledge, but it gives you half-baked knowledge, or you cannot connect the dots because you're not qualified. So while you may read, this medicine will create this problem, that medicine will not suit me, so you avoid taking it, or you don't inform of that you haven't taken it, the doctor could have changed it. So again, that becomes another problem. Yes, once that is done, settled down, the very prescription sometimes is scribbled in such a manner that it is difficult, the legibility, the dosage, how to take it, when to take it. As Dr. Kavaldeep said, should I take it before the meal? I don't mean the prescription paper itself, but the medicines, maybe empty stomach, maybe after a food, maybe early morning. It's like shake the bottle before use, the very old joke when the person drinks it and then shakes himself. So that doesn't help either. So very often, people also do not understand the basic nature of the salt, so they go to the chemist and then again things change. A very important gap arises when the family member or the concerned person who listened or took the discharge summary or took the prescription goes back home and relays it to another member of the family. It could be the patient, it could be a member, and then it's lost. The details, the nuances are lost. And this happens with nurses, with doctors, with junior doctors. It happens in the entire journey, in the entire spectrum of care. So there are gaps in the prescriptions. A very important point that is not mentioned here is when the doctor prescribes it, they sometimes give experiments, or the latest drug because somebody gave a sample. But can that be continued? Will that be available? What is the economic background? Can the patient afford it? Will the patient go back home and continue to take it? I think these issues must be understood before just writing a prescription, so that it is doable, it is realistic, and not just classic. Tamanna, next slide, please. And the patient level, there's lots there at the patient level too. As I said, there are taboos, there are myths, there is lack of understanding, and I think Professor Sangita has highlighted the education of the public, which I have seen in my experience as a volunteer with cancer patients, in my experience with substance abuse children. I think educating them that this is not going to give you harm and it is good will serve a long process. Somebody also said we prescribe, but we don't know whether the patient takes it. So it's a blind wall there. You can't assume that what is prescribed is also subscribed and the patient has followed everything. It could be overuse, it could be underuse, it could be irregular use, there could be time lapse, people go back home, people lose touch, they have another emergency in the family, so they ignore taking their own medication, and it could be wrong time medications. Things can go wrong because it was not taken regularly. Another very important part, I think medicines are one important area, but it's not the whole. So a holistic treatment, as we all know, includes diet, rest, maybe even other interventions, maybe dialysis, maybe chemotherapy, and medicines. So when you do not take one and just take the other, it could be incomplete cure or incomplete results. And we would blame the harm that's been done because of the medicines. There are myths as well. I mean, I know both, I mean, in our own family, they did not, one particular branch did not take the vaccine because they thought it is not tested, and anyway, we'll probably go blind, or we'll have other symptoms, or our heart will stop. So there are a lot of risks associated but not clarified. And whatever is written on the medicine box, it's much too fine. It's not readable, even with a magnifying lens. Maybe we need to get into graphics, maybe we need to get into color codings, but just writing in fine print satisfies the pharmacist or the drug makers, but not the patient. How to take the medicine is as important. Hygiene, both for storage, retrieval, and for disposal. Storage we've talked about earlier a little bit. retrieval, sorting them out, checking the age, all these are very important, particularly for medical devices, even if it's an inhaler, even if it's just a thermometer, even if it's just an oxygen monitor. You need to clean those instruments. You need to clean that nebulizer mask. Otherwise, you're inhaling more medicines, more dirt, and one is stronger than the other. So checking and keeping that your hands clean before and after is not just during Corona, it's always important. Some things do cause us side effects and we just ignore it. Yes, stomach upset, maybe I ate something, but it could be related to any particular new medication that you started or not started. So observing, noting it down, and reporting it back. All of these needs are from the patient side. Home remedies, yes, for small items, definitely. We can't go to the doctor all the time, but not always. For major illnesses or anything that is important, or I have one formula which we've learned by mistakes within the family, as a patient, as a caregiver, and observing others. Any symptom that goes unchanged or unrectified for more than 3 months, 6 months needs to be reported. So just a home remedy is not good enough to clear it out. So again, there's a patient engagement with the doctor as a collaboration that would help. Tamanna, next slide, please. So where does the pharmacy, Tamanna? Next slide, please. So where does the pharmacy come in? There are two kinds of pharmacies. Yes. So the pharmacy understands the prescription, hopefully. He's not just the son of the father who started it. And they do not have the medicines, as I earlier also mentioned. So they may give an alternative brand, or is it an alternative salt? So when there's a change and when you don't get it, then people switch, but maybe the dosage is different. Maybe the instructions need to be different. Maybe the accessibility is not there, so you compromise. But all this can lead to harm. And this is where the pharmacist comes in. And it's his duty to either call up the doctor or tell the patient to call up the doctor and not become the doctor himself. So the caution has to be mentioned both by the doctor as well as the chemist can come in here of usage, overusage, anything. I have two other definitions of pharmacy, a travel pharmacy and a home pharmacy. When we travel out, I think it's nice, not nice, it's important that we carry a copy of our important medication that we take regularly, including the basic composition, because when you go abroad, you may not get the same name in the medicines, and then even for a Disprin or an aspirin, you're struggling around. So a travel pharmacy, carry your basic medicines, it's allowed, and also the prescription to go with it, and also the generic names from where you can source it. The home pharmacy is your most comforting place, most important place, cleaning it up periodically, checking the dates, keeping it away from children, not throwing away excess or old medicines, give it away. Disposal of injections or injectables, all these become a part of the pharmacy level at your own. And people, all of us, including us, we need to keep the lists, understand them, and look after it. Yes, Tamanna, next. So it is up to us. Next, please. So we need to empower ourselves. We need to understand that it's a collaborative effort. We can make things better. And Patients for Patient Safety is one such initiative started by CAHO under the WHO program, wherein we are inviting stories, experiences of the general public, general patients, which have suffered avoidable harm. And the reason is not to throw the blame. It is absolutely not for that reason, but it is to learn. Anything that you want to share, please share it. There will be a repository of advice, information, public patient support groups, so that you can avail of services even without going to the doctor when the doctor doesn't have time. And with those stories, we want to cull out, there will be a panel who takes out lessons and shares it with the regulators, with the medical fraternity, right from training to. So help us to help everybody. And I'm so glad about this forum, and we wish it luck, and we wish more and more people join us. Thank you. Last slide. Yes, thank you. Thank you.
Thank you very much, Dr. Chaturvedi. I think you've really hit the nail on the head there when you talked about some diseases which have got social, employment, and other discriminatory angles to them. They'll be less likely to be prescribed, used, and corrected through the patient's life. I think this is something very common. I know of Indian hypertension patients. We were asking some men as to why they hadn't been taking the medication during working hours, which they should have. They said, if my colleagues saw me take this medication, there's a likelihood of my employer might fire me, or I might not get that promotion in job. And I think that stuck with me entirely, that we need to change social attitudes. And you've really nicely put everything together and said that the science of that medication is not enough. The overall cultural surrounding, it's very important. For my next speaker, I think it brings neatly into this, they say that if the carrot doesn't work, then the stick will have to be used. Now, for that, I will bring in the regulators. And I think the European Medicines Agency, as a nice regulator, we have a very high authority. As patients for patient safety, I tell you, they're really nice. They open the offices up and you can visit everybody, talk about everything, any questions, and there is no us and them, uch needs, this job path and this. It's everybody's equal, whether you're from right at the edge in Poland or in Slovakia, or you're from high German countries, we don't care where you're from, you're part of that same picture. So I would like Maria to now talk about reporting on patient safety, and it's very important how it's done, and we see what the European Medicine Agency does. Maria, over to you. Thank you.
Thank you. Thank you very much, Kawaldeep. And it's really an honor to be here to speak to you all and to speak after these two wonderful presentations already, which have really, I think, set the scene. We're changing gears a little bit, as we said, going to the European Medicines Agency. And so I'm just going to share my screen now and begin, just to give you an indication of the work that we do. So I'm going to just talk about a little bit to introduce everyone to the European Medicines Agency, a little bit more about how we involve patients at all these different levels, and also to talk about how patients are involved in medicine safety activities within the European Union. But just a word to say who we are. And so the agency, the EMA, the European Medicines Agency, has existed since 1995, and we represent 27 member states and work with around 800 staff members. But we work extensively with Europe's from experts from all across Europe, and the experts include patients, healthcare professionals, and regulators, of course, as well as academia. And apologies for all of these acronyms, but the experts also form the committees that evaluate the medicines. So we have the Committee for Human Medicines, the Committee for Veterinary Medicines, Orphan, Herbal Medicines, Pediatric, Advanced Therapies, and the last committee that was created, well, now it's 10 years old already, but the Safety Committee, or the Pharmacovigilance Risk Assessment Committee. We have a management board that governs the activities of the agency, which is made up of these members shown here. So very importantly, as I said, we have patients that are involved in really every aspect. I'll tell you a bit more about that. But firstly, what do we do as a medicines agency? And this is the same as every medicines agency does, but if we look at this in 4 broad lines, we facilitate development and access to medicines, evaluate applications for marketing authorization so that the medicine gets put on the market. We monitor the safety of medicines all across the life cycle, and we provide reliable information, which as Dr. Chaturvedi was just talking about, it's very important to make sure we have access to reliable information for patients. So today we're focusing more on the safety of medicines across the life cycle. Just to introduce a little bit about patient involvement at the European Medicines Agency, if we divide the regulatory life cycle of a medicine into 3 broad phases that we can see here, the pre-submission phase, evaluation phase, and the post-authorization phase, we can see here with these little symbols that patient input really is at all phases of the medicine. So in the bottom, in the circles, we see the same acronyms, and we see the different committees that are active either in early phases or later during the evaluation and post-authorization phases. And patients are either members of the committees or they're consulted by the committees. Patients are also important for reviewing documents that are sent out to the public, because as we talked about, this idea of making sure that the information is clear for patients and ensuring that it's written in a language that makes sense and that it's aimed at the right level so that people do understand the information that's been put out there for them. Because of course, we're a scientific agency and our information is evidence-based and scientific in nature. So communicating at the right level and the right way with the right end user is very important. So to focus a little bit more on the safety aspects, in these early phases, while safety is of course always an issue, safety really comes into play when we come into the evaluation aspect. So here we're focusing on the committee that we call the Committee for Human Medicinal Products. And this committee really is the committee that evaluates what we call the quality, safety, and efficacy of a medicine. It is the committee in Europe that will give an opinion on whether the medicine meets these requirements. And we talk about a positive benefit and risk balance to make sure that the medicine works and that it doesn't cause harm, or at least if it does, that there's a positive benefit risk, that the benefits outweigh the risks. So this committee will evaluate, as I said, the quality, safety, and efficacy. There can be an accelerated assessment based on whether the medicine is of a major interest for public health. And for new medicines, we also have this inverted black triangle, which is found on the box or in the package leaflet, which shows that the medicine is still just being monitored to make sure that it continues to be safe, and there are regular updates on the safety. Importantly, the involvement of patients at this stage can happen in various ways. So patients can be invited to participate when the committee is meeting, and they can give their input into what they consider to be the benefit and risk of a medicine to that particular patient community. We can also have expert meetings, which are indicated here, which I'll talk about a bit more in the next slide. And we can consult larger groups of patients via surveys or by addressing organizations and asking them about the burden and the benefits of the disease in question. And that feeds back into the evaluation by the committee. So talking a little bit about these expert meetings, what we see is they're called scientific advisory group meetings or ad hoc expert groups. And the difference is basically that we have 5 established scientific advisory groups in the areas here, such as anti-infectives, cardiovascular, neurology, oncology or viral diseases, and any condition that falls outside of these therapeutic areas, we convene an ad hoc expert group. So within these groups, these expert groups, we have leading key opinion leaders in these specific areas, and we systematically invite patients and healthcare professionals to also participate in these meetings. Here in the link, and you'll have the slides later, you're very welcome to have the slides. There is a link to our website, and we just show that 25 patients were involved in 14 scientific advisory group meetings in 2021. This is just one activity where patients are involved, and you'll remember in one of my previous slides that patients are involved really all along the medicine's regulatory life cycle. So here we're focusing really on safety activities. We are looking at, in particular, the post-authorization phase, where we also see the safety committee or the PRAC. Here we have a patient member and an alternate member that are part of the committee that have exactly the same voting rights as every other committee member. And on the committee, we have representatives from each of the European member states, And so this is important that you know that there is a patient member and alternate and a healthcare professional member and alternate who bring the opinions of European patients and European healthcare professionals and bring that important perspective. Other ways that we handle or we tackle this issue of safety within Europe, we can have public hearings, and public hearings are when there's a particular safety issue or safety referral that has been brought to the attention of the committee, and the committee is evaluating this, and it concerns a large number of patients. It's of public interest. It has a relevance where the committee would really like to hear from the public. So we've had 2 of these meetings so far. One was in 2017 on valproate-containing medicines, and the second meeting we had was on quinolones and fluoroquinolones. We hope to hold more. Obviously, we hope to have more medicine safety, but where there is a need, we absolutely would like to hold more. And now that we're relocated and established in Amsterdam, we have the facilities to do this again. Other ways that we interact is to also hold stakeholder or multi-stakeholder meetings where we once again invite patients and healthcare professionals to discuss with the regulators about issues such as, again, valproate, for example, which then led to a public hearing, retinoids, and methotrexate, which was one of the most recent issues where we had medication errors as well. And there was a lot of discussions. There's recommendations that are made that are then considered by the committee and put into their output. As I mentioned, there are documents that are produced, in particular when there are safety issues that are arising, that are signaling within Europe that there's an issue going on. The committee will very quickly review these, and then there's a communication that's put out that explains to patients and also to healthcare professionals the particular issue. And as I said, these safety communications are always reviewed by patients and also healthcare professionals. And in 2021, we had 25 reviews by patients. Finally, as I also mentioned, when we're trying to consult a larger number of patients, we also do surveys to large groups of patients to inform the committee in their evaluation process. So I hope you can see that all along there's lots of different methodologies that we use. We engage patients at different levels, either as members, as experts, and also just as the general public who can come and give their opinions and input into the recommendations of the committee. Very importantly as well, and I believe that Dr. Sharma, Professor Sharma, talked about the reporting of side effects by patients, and this is also possible in Europe. I've put this here as well. It's the website for the reporting of side effects. You can click on this link as well. It's ADR, Adverse Drug Reaction Reports.eu. This opens up to this page here where you can either report on human or veterinary products. And if you click on human, you can see that it opens up to a link in each EU language that will take you to the relevant authorities where you can report in your own language about the particular side effect that's being experienced. Here, there is also a link that leads to a very nice infographic about how you can report side effects that explains step by step. And also it explains where you can find the side effects that have been listed for a particular medicine. I think this is also very interesting for people as well. So here we encourage people to go to the relevant site and report in their own language. And as was stated already earlier, this is a very important activity. Obviously, patients can report to their healthcare professionals who can then do the report, but it's also very important to know that you can report yourself. So in this, my final slide before my conclusions, I just would like to reiterate that this is the pathway and the outcome for reporting and monitoring the safety of medicine. So as we've already said, patients can report themselves, or they can report to their healthcare professionals who can report. We access information from clinical studies, medical literature, patient registries. Also, there's regulatory bodies outside of the EU, outside of the European Union, who can report, and then we gather that information as well, and signal detection. This information is all filtered through the committee here that I talked about, the safety committee, the PRAC. And again, just to remind you that there are patients who sit on this committee. who also look at the assessment, the evaluation of the safety risks. They form part of the recommendation. And then the decision on what to do with this medication is made by the committee, and it can either be that the safety signal is sufficient, it's not really a threat, and so to maintain the authorization as it is, to make a change, to suspend the authorization for a particular period of time, or to revoke it altogether. And then this is communicated to the regulatory network within Europe, and then the final decision in our case is made by the European Commission and the individual member states. So just to conclude, I hope you've understood that patient involvement in EMA safety activities is really all along the life cycle of a medicine, that we have patients involved in the safety committee who are involved in voting and decision making. We have lots of different methodologies to make sure we capture the voice of patients, either in multi-stakeholder meetings, public meetings, scientific advisory groups, and larger groups of patients via surveys. And of course, individual patients can report their own adverse effects directly to their national authorities. So with that, I will stop sharing. Thank you very much.
Thank you, Maria. I think you saw that framework on reporting adverse events. And I must tell you that behind the scenes, I think this is something we always try to emphasize, is that the amount of artificial intelligence, digitization that goes on, links between the front line to the back end is enormous, you know. And anybody who goes onto the website and reports it, it will be filtered straight down to where that pinpointed where the adverse event has actually happened. And sometimes what is going on is that we are now emphasizing that many medicine products have barcodes and also QR codes on them. So the barcodes is for the health professional teams that were there, who have got readers who quickly check up what's happened, and the QR code for anybody else who's present there as to what that medication is, what is indicated. Because if you find an adverse event, a serious adverse event, the patient is most definitely either unconscious or not compos mentis, and then you can't ask them, what drugs are you taking? You search their pocket, bring it out, QR code it, and then quickly feed it. And therefore, then that picks it up. So that approach has really helped us. And I've seen in the comments about telehealth, and yes, India could take this on board. I think India leads on QR code technology, supplying to everybody else in the world. As a pharmacy to the world, for a start, it's supplying drugs, but then also from IT, you know. I mean, in the UK, we have got our Chancellor, Honorable Sunak, whose father-in-law happens to be Murthy from Infosys. And I said, you know, you guys have been giving us this, why don't you spread some good news amongst your own countries? So it's very important. Now, the next step I'm going to take is, I think, to share that in this whole approach, the engagement of all the stakeholders we have said, okay, here's a state, here was what the family and the patient was doing, and then we talked about looking at the regulators. Now, lastly, I'll now call upon Alice Ladzeni, who is our Patients for Patient Safety champion member in WHO, and he's on the IAPO board. And Alice has a long history of participating in coming up with strategies and recommendations of involving patient organizations in raising medication safety awareness. And he will discuss to some degree the Global Patient Safety Action Plan, what it's saying for family and patient engagement. Do read that. We will send that link into this today. There are certain things that the family and the patients have to do to ensure this Global Patient Safety Action Plan is brought in. Alice, could you now take over from here? Thank you. Alice?
Well, thank you very much for this opportunity to make a presentation. It becomes a challenge to make a presentation after all the eminent people have said it all. Nevertheless, I'll put in and present what I have. Basically, my presentation will focus on experiences in the developing country, as well as those that affect the marginalized, as well as the less privileged people that live in the rural areas or peri-urban areas, those that don't have the medical health insurance. So that will be my focus. Next page, please. So my presentation will look at the characteristics of patient organization members, the role of patient organizations in patient safety, the challenges which patient organizations face, and analysis on the way forward. How can we support patient organizations so that they actively and effectively participate in the patient safety activities? Next slide. That I've covered. What I said is the characteristics of patient organization members. Most members, as I said, they are from the rural areas with low literacy levels. As such, they see health service delivery, which they receive as a favor. They are disempowered members. They don't have a voice, and in most cases, they are not engaged by the health authorities at all levels, national, either central, or even at grassroots. Because of all these factors, when they experience harm or notice unsafe practices taking place, they remain quiet for fear of reprisals. They don't raise any alarm. So that becomes, that's what most of the members in the developing countries are. Next. The next slide. Now, when it comes to role of patient organizations in patient safety, patient organizations act as a mouthpiece for the patients. They promote meaningful engagement and involvement of patients. They provide a two-way channel, hence they act as a link with the public, healthcare professionals, and the health facilities. They also raise awareness on safety issues and the patient provider rights. That is, they are engaged in public education programs. In addition to that, patient organizations act as a platform for sharing healthcare experiences of avoidable harm or unsafe care and the best practices which can be taken in order to safeguard anything on patient safety. Next one. With regard to the patient organizations also, they act as a repository in terms of obtaining incident reports from their members, patients, or families and guardians, and they disseminate such information back and forth between patients and the health professionals for corrective measures. They are also involved in promoting patient safety in order to ensure that there is quality improvement in the healthcare delivery. Sometimes patient organizations, if they are well funded, they conduct face-to-face dialogue with their constituencies. Hence, they have real-time information on patient safety issues and medical harm incidences. They have a whole lot of experience in patient safety derived from those with living experiences. Now, what are the challenges? In spite of all these positives which patient organizations can provide in patient safety and healthcare deliveries, there are challenges which sometimes limit how far they can participate and perform. As I said, because of the status of the patients, most of them, they don't report whenever there are harm incidences. This has a negative effect because then if there are any mistakes, those can continue. The other issue is most of these patient organizations, they don't have the resources and the equipment to use in reporting incidences or unsafe practices to their respective patient organizations. Patient organizations are also challenged in terms of their technical ability as well as financial muscle, so that they should be able to undertake various activities. Next one. Most of these patient organizations are run or set up by passionate members that have adverse experiences. As a result of this, you find that their resources come from the contributions of the members themselves, and most of them work on voluntary basis. In the case of funding, in most cases, it is project-specific funding with restrictions on its use. Now, because of that status of these patient organizations, we find that most healthcare policy makers and professionals, they shun them and they don't make efforts to strengthen them. They don't even engage and involve them in a number of activities. The other challenge which is there is the media. The media in most of African countries, it is extremely commercialized, making it impossible for patient organizations to use it to reach out with messages to their members in a speedy and cost-effective manner. That limits how much information patient organizations can share to their respective members. Next slide, please. Now, in spite of all these challenges which patient organizations are facing and continue to face, there is a World Resolution 72.6 on global patient safety, which called upon the Director General to provide support to member states upon request in putting in place systems to support the active engagement, participation, and empowerment of patients, families, and communities in the delivery of safe healthcare. This resolution was made in 2019. Yes, next slide. The resolution further calls upon the establishing and strengthening networks for engagement of patients, communities, civil society, and patient associations. This covers support to patient organization. This resolution has been clearly captured in the approved Global Patient Safety Action Plan of 2021-2030 under Strategic Objective 4.1 under the heading Patient and Family Engagement. Next slide. Sadly, despite this 2019 resolution, very few WHO country offices and member countries have operationalized that resolution. It means patient organizations are still crippled and disempowered. Most health ministries are still operating in the medical model mode, with total disregard of the importance of engaging patient organizations and including patient perspective in their activities. Next slide. So how do we move with all these challenges, with this inaction by some of the member states? What should be known is that patient organizations are best gatekeepers to support the attainment of zero harm and patient safety. There is therefore need to seriously review implementation of the World Resolution with clear, tangible deliverables and monitoring mechanisms of the member countries, especially in the low-income countries and Africa in particular. It's unfortunate that the implementation of this resolution was left for countries to seek support to WHO when it is the same member countries who do not have an interest to work with, to work closely and support patient organizations. Next.
Alice, you've got one more slide and then we'll conclude. Yeah, please carry on.
Okay. So efforts as a way forward, we must also be made to create or strengthen regional and national patient alliances Unless if the value of patient organizations is given high priority and recognition, the attainment of patient safety will just be an illusion. In conclusion, next slide. In conclusion, zero harm and safe practices in healthcare facilities requires multi-sectoral and concerted efforts of all key stakeholders. Patient organizations who comprise the end users of health services must not be left out in this process, but needs strengthening. A revolutionary mindset which maximizes engagement of patient organizations must be embraced in order to attain zero harm. I thank you for your attention.
Thank you very much, Alice. Okay, I've got questions coming thick and fast, and I will take them so that we can quickly come to the points. We'll try to answer all those questions over time. We're taking notes and we'll email everybody. But the first one, I'll open with Maria. Maria, if I know it's the diplomatic conventions and protocols apply, but the question was if the Indian regulators, as SEDESCO or others in the region, would like to create those pathways that you patient engagement, what are the essential ingredients? What should we be doing? What should the regulator be doing to encourage these pathways so patient can engage in medication?
I think the first thing is to create a situation where normally patient groups are very active and they normally would come to the regulator, which is certainly what happened in Europe and I imagine in other places as well. So I think to kind of create a relationship to exchange with the patient groups already is a good starting point. We are always very happy at EMA to share our experiences and to share even, we have framework of interaction with patients. We have all sorts of frameworks and experience. We're very happy to share our experiences. I think that patients will often come to you to speak about their needs. I think the first step is really to listen, to engage with the patients and also to see where you can exchange and where you can involve patients in your work. They have, patients have a wealth of information about living with conditions and what's important. And I think that's the first step, to maybe have an open and frank discussion about what they can do and what to really be clear about the expectations as well, to make sure that the expectations are realistic on both sides.
Thank you very much. I think you've put that enabling environment. I think getting that atmosphere and trust developed. And I think Indian Alliance of Patient Groups has been active, and now the Patient Academy. I think it will be very good to see how we bring this about for the Global Patient Safety Action Plan, because it becomes very embarrassing for us, when we meet in Geneva or elsewhere, and you ask the minister concerned, do you have this engagement? And the minister says, I haven't thought about it. And we would like to be proud when we meet our ministers in Geneva. Thank you. And now to Professor Chaturvedi. I think one of the question is, how can we raise the importance of pharmacovigilance within patient engagement and try to prioritize this in safety? How can you do this? What mechanisms can you suggest we could raise? Because I know very often when somebody's having an adverse event, we just lie down and we don't report and we don't say anything, and we try to tolerate it. How would you go about bringing this about, that somebody needs to know and it needs to be reported?
No, I agree there, because most of the time patients do not report it. Maybe because of lack of time, a lack of faith that they will be heard, or just fear that the doctor might get angry and not treat us properly again. And that even that fear is there, because it's a God syndrome here, and this lack of time. So I think talking within a patient support group or a forum like the P4PS, the Patient Safety Group that Kaho is putting up, and inviting their experiences without naming them incognito, and if possible, meeting in small groups and talking to a cluster of people with the same disease or same problem could also address the issues. And collating that information and then sharing it with the regulatory bodies or the doctors or the hospitals or the HCPs, that would help. But it is necessary, I agree that. And it's difficult because of the fear of the patient himself.
Thank you much. That's brilliant. Good. Now, the toughest question I reserve for Professor Shema now. This has got a very Indian look to it. You know that family structures are such that you have senior parents, we do respect them enormously. Then you have junior family members who are very active and are always on Google searching things and all that. And then gender play. And going back to that old Hindi thing, you know, Saas bhi kabhi bahu thi. How can the bahu, the daughter-in-law, bring intelligence into the family? Is there a way to do this? You know, I'm saying this, we are hosting of a Matadora. This is Award for Women Scientists next week. And this is a question coming out that during the pandemic, women played a big role in health, you know. And we know UN statistics as well, invest $1 of health in a woman and it trebles into $40,000, $50,000 in elsewhere. So how would you go about this? How can we bring women and younger members of the family into?
Yes, I know, very, very pertinent question. I would give you the example of firecrackers, you know, on Deepavali, if you remember in India, crackers, you know, this campaign, you know, the messages were going on for several years to reduce, you know, pollution, that, you know, firecrackers should not be burned, but it wasn't, you know, making any headway. But the moment the children were involved, you know, when this campaign started in the schools, you know, the whole change was brought up here. And now you see, you know, still we haven't got rid of this problem, but if you know, see over the years, the firecrackers, the number of them is going down. So following the same approach, you know, taking lead from here, we use this antibiotics campaign. So I think wo saas bhi bahuti thoda sa invert, if we see this inverted way now, things have changed, you know. There is a whole lot of change in the culture now. Parents have to listen to their children now. So I think the schools are the places, you know, where, you know, our, you know, generation is over, you know, past now, where we used to listen to our parents, but now I think it's the other way around. And it is working. It is working. And definitely women empowerment, and if they know, because they take care of the all the, you know, medical care and the nutrition needs. So if you empower women in the house, it is certainly very useful.
Thank you much. I'll now finish this very excellent session. I think we have run over time, but I know it was a fascinating time, and I think we really learned. I heard the best one was this young girl was arguing with her mother, you know, and about some issues of some medication, and she said to her, "Google Masi kehti hai."
Yeah.
Google became a Masi, you know, like an auntie. Google auntie says I should take this, you know. So yes, yeah, absolutely important. So I must thank all my very excellent presenters. I think you've done a fascinating first job, and I think it was a very difficult challenge to push the car. You know, once you pushed it, now it will roll. Thank you for giving me a help into that, push this car off, and we will now roll it. And as I said, medication safety is for all of us. It is a whole of society, whole of government, and whole of patient groups' responsibility. And we must rely on modern techniques, traditional approaches, but very much center it in the cultural sensibilities of our environments. But also post-pandemic, let's build back better and create that an Indian patients for patient engagement framework that Maria has given us a very good roadmap of. And let's make sure that on 17th September, everybody please wear orange. I mean, it's an unfortunate choice of color. You know what I'm saying here now. It's an unfortunate choice of color for India. The color chosen is orange. And we want to make sure that we mark that World Patient Safety Day on 17 March. And light up your houses with orange and wherever you can, and share those with us. So we will post this, everything. And with that, please do have a nice Saturday afternoon, evening. And do take care of your family and friends and spread the good news and join us again. Thank you very much.
Thank you.
Thank you. Goodbye.
Thank you.
Bye.
Bye.